But earlier this year, we wound up a fairly large imaging study in patients with visual snow syndrome, interrupted by COVID, like most things in the universe. Using the 7T scanner, we collected 70 scans, including resting state, structural scans, task-based functional studies, mapping of the visual cortex using checkerboard stimuli. And I've got a postdoc working on that data, unfortunately around only 1 day of work until the end of the year. So we should have some of the results ready for publication by the end of the year. Plans to have a look at the ocular motor tasks that we found to be quite clever at dissociating those with and without visual snow, and having a look at that in the scanner, as well as some EEG studies, sort of once again looking at those behavioural changes that we found in visual snow syndrome.
I think the thing that I'm most excited by within the imaging range of portfolio is spectroscopy. Interested in the chemistry of what's happening in the cortex in visual snow as a said way to understand what the probable target or what medicines one might be able to repurpose logically to begin to think about therapeutics. So for me, it's functional imaging.
We have three main aims. One is to just determine, are there any untoward effects of repetitive TMS for visual snow syndrome, since it has not been reported in the past. And number two is really describe the changes in outcome measures for visual snow syndrome, sort of pre and post.
Interestingly, the visual snow patients, they also report having tinnitus. And of course, we all know the patients who have tinnitus as the main problem. Or we know patients who have pain that's unexplained as the main problem. That's called fibromyalgia. And there are different forms of vestibular problems that are continuously present. And we think that visual snow is kind of a processing problem of visual and non-visual information. And taking this all together, it's probably not any single area, Victoria, that is a problem in these patients. It's probably not only the lingual gyrus, but there are many brain areas that are involved in this condition. And those brain areas seem to work with each other. And so it might be a network problem, so that several brain regions, they interact differently. And one of those networks is the salience network. We can see that here with the insula as one of the main areas involved. And that's one of the areas that Francesca also found in her functional MRI studies to be pathological from that in visual snow patient compared to controls. This is where we come from and where we are going to. And from also the work from Flavio, we know that when you combine this electric stimulation with interventions, the effect of modulation can be enhanced. And that's why I'm happy to be here today, because there are some others from this group who use some of these interventions successfully. The studies we have planned until the end of next year is to get this clinical trial on transcranial electric stimulation going. We already have two, let me say, we have two steps. I don't see my screen now, but we have two steps. And the first step is to identify the goal, the target to be modulated. And that's what we are already working on. So Antonia, in her long and much free time, she's trying to identify the algorithm from patients using EEG in VSS. And we have more than 20 subjects, and we have 40 controls matched for all kinds of things. We are very, very confident that we will find a nice target that then should be modulated data with a good protocol together with Flavio. Now, the second study, just briefly finding a validated diagnosis of visual snow syndrome. Here we have ethics approval for doing a study, which has in the center a questionnaire that's validated for the diagnosis of VSS that should be online and worldwide accessible. It can look like this. We offer 6 pictures to patients, and if you chose the right one, here you don't have visual snow. If you have visual snow, you have a likelihood of 1 in 6 to accidentally choose the right snow picture. That's this one. And all the rest are distractors. And we have that for all the symptoms in visual snow. And we think that this is very important to have such a questionnaire that's available for everybody, because it can homogenize groups worldwide. And I think this is really an important step for future research, and also for the clinic, because patients then can say, in this questionnaire, I have this and that point, and my diagnosis of VSS is that likely or less likely. And to quantify the severity of visual snow, we have several projects at the moment. It's also an online tool where we will be able to probably tell if somebody has more severe density, more severe flickering rates in visual snow than others. And that's also, I think, very important on one side for research, but also on the other hand, for questions such as insurance issues or work-related issues, because that's what the patients often come from in the clinic, and that's what they ask us. And we are, unfortunately, at the moment, we don't have equipment to say this is very severe visual snow or this is less severe visual snow. So that's it from my side. So we aim at identifying an EEG signature and use that signature to modulate the syndrome. And we have 2 other little projects going on when we have some time. So thank you.
When Terry and I first talked about it, we really wanted to figure out a good way to do a study. Being both clinicians, I think we felt like doing a quality of life survey was really a good way to approach it. And so we found a standardized QOL survey that we utilize. And part of it as a clinician is, you may improve a person 20%, but their quality of life may improve 70% if you just improve them 20%. So I felt like that was kind of a better scale for us to do. And we did submit this to an IRB, did get IRB approval for this study. So basically, what we do is we submit them to this QOL study 3 times in our 12 weeks of neurovision rehabilitation. We do it initially, we do it halfway through, and then we do it at the end. Today is the last day of enrollment on the study, I'm happy to say. and then hopefully we'll have most of the neurovision rehabilitation completed by the end of the summer, and then hopefully can report back to you sometime after that. Some of the commonalities and interesting things that I've seen with this, obviously, we've seen really kind of, I really kind of want to characterize these people in 4 subgroups. We've seen those that have a high commonality toward migraine headaches, those with concussion and traumatic brain injury, and then those with anxiety and depression. Those are really the 3 areas. And the 4th area is what I call other, because I've had 1 stroke patient, I've had a few others that kind of didn't fit into a category, but those are really the 4 categories I'm hoping we're going to be able to transition our patients into. When they came, we did all the sessions to this point have been done live in our offices. Although we hope to find a way to be able to transition that into a remote therapy. I've already been training one of my therapists to do remote therapy. And hopefully we'll be able to, that would kind of be our next goal, is to develop some remote treatments that can be beneficial. I do think it's going to take longer to do a remote treatment than doing it in office. But obviously, if we want to open this up to the world, that's going to be something that we're hoping to do. And obviously, we want to see the results of this study, because I haven't seen the results yet. I've talked to a few of the patients as they've gone through it, and doing evaluations as we've gone through it, and have heard some real positive things. And then we've had several people who have actually continued therapy post-study because they had seen enough improvement, they wanted to continue to have improvement. So I think that's really a positive sign that we're seeing some positive changes in the long term.
Do you mind just maybe briefly outlining what you mean by visual rehabilitation for the uneducated?
Oh, okay. Visual rehabilitation is using some, for lack of a better term, we do some it's really a neurological approach to visual processing. We try to improve visual processing. So it might be things like tracking activities. It might be things like working on visual spatial skills. It might be something like working on accommodation and convergence skills. It's working on even for some perceptual skills. Although I found the other interesting thing that I found in all this, almost every single patient that I've seen has been highly intelligent. I've done visual perception tests on almost every single person, and their results in just about every case were through the roof. So perceptually, they're highly intuitive. So I think where we try to work on all the areas that we typically would work on, as I said, in cases of acquired brain injury. And I think that's kind of where that was kind of the basis of what we did on our initial patients. And so we decided we want to carry that exact thing over to what we would do for the study. And that's pretty much how we came across came about the study protocols, was by basically following what had been successful in the past.
I see. So it's kind of like visual perception, 3D, kind of maneuvering around environments, visual field, eye movements or something. Do you also do eye movements? Oh
yeah, we spend a lot of time on eye movements. I wouldn't say we spend a lot of time on perception, actually, because as I said, most of these people have done really, really well on perceptual tests. I think I spend a lot of times on working visual spatial skills, I think probably more than anything else. But obviously there has been, I've also noticed preponderance toward accommodative visual issues, where, in other words, going from distance to near to distance smoothly, efficiently, and accurately, particularly on our younger patients, which I've seen quite a few younger patients, that accommodative system seems to be locked down a little bit. So those are some of the things that we have seen pretty consistently. And then, of course, ocular motor, working on pursuits and saccadic eye movements.
And how do you decide on the treatment protocol? Do you go with the standard sort of set of treatment, or do you tailor it according to your findings?
Well, what we did is we actually created a series of different elements. So we like a visual spatial element, monocular skills element, like for accommodation, and monocular visual skills. Then we created binocular skills and perceptual skills. And what we did is we created a series of different activities for each of those skill levels. And then what we did is we turned it over, and we were doing the therapy aspect of it. What we did was we said we can choose anything in this category and do it, and that's how we kind of individualized it. But they had to do a certain amount within a certain category, and then move to the next category, do a certain amount, and so we kind of that way we can control the outcome based on skill sets.
How I got involved with Visual Snow is kind of a roundabout story, but I had a patient, I'll share a little bit, 25-year-old male, very frustrated man, lots of visual symptoms, shimmery vision, palinopsia, dots in his vision, flashes of light, all the things. By the time he came to me, he'd already quit college. He had moved back home, was living with his parents. He was not leaving the house. He wasn't really living life. He did, however, a lot of these patients are so smart and so research savvy. He had found the Visual Snow Initiative conference. So he did make his way to that conference. And he was listening to all the lecturers, and he talked to Dr. Pellick after his lecture, and he asked her, is there anything that I can do? So she recommended perhaps trying some filters, light filters. And since we're in Southern California, there's a doctor, Rebecca Kammer, who's very, very good with light filters. So she referred him to Dr. Kammer. And Dr. Kammer is an awesome doctor. She's a low vision specialist, and she does a lot of work with filters. So she happened to be working in my space, in my office at the time. And when she was assessing this patient, she knocked on my door shortly afterwards. And she said, the thing is, this guy is so visually symptomatic and so frustrated and so upset and angry. Like, I'm going to do the filters with him, but I really don't think it's going to be enough. And knowing the work that I did with patients with interesting visual symptoms post-traumatic brain injury, et cetera, she's like, you know, is there anything you perhaps can just try, because he's not functional. And of course, he's coming from far away, so maybe you can see him right now. So I accepted him to come in, we did an assessment. And just like Charles said, you know, I didn't know Charles before, but based on history, based on signs within the examination, there was enough similarity with the work that I did with post-trauma patients that I thought, you know what, let's try. And this patient, again, had been to, his father was a doctor, he'd been to all these different doctors, and everyone had already told him there's nothing you can do. So he was willing to do anything because he didn't have anything else. So he was very open. And so we started working together. We did about 7 months of therapy. And by the end of the therapy, as we chatted, he's like, oh yeah, by the way, I'm moving to Oregon. And I'm like, what do you mean you're moving to Oregon? You were living in your parents' basement and you couldn't leave the house. And he's like, yeah, he managed to finish college. He found his dream job in Oregon and he moved away. So he has such visual symptomatic, reduction, quality of life just went back to normal, and he's doing very well now. So that's how I got started with my first VSI patient and visual snow patient, sorry. And I guess word spread a bit and I've had some more success. So then I got introduced to Paul with BSI, who then introduced Charles and I together. And so we tried to design a study that really did look at quality of life, because again, for our patients, that's what they really care about. What's happening on the screen for the patient? They're looking at a screen. And for example, for this top column here, they're following a little circle. And the test in total lasts about 3 minutes. So each subsection, maybe 30 seconds, but they're following a little target and then it's collecting some data. In this sequence, they are following a little dot that moves across the screen, pursuit skills. In this section, they're following a vertical dot up and down the screen. On this one, she is doing saccades, horizontal saccades. This one is vertical saccades. And here is her fixation skills. So I'm not going to get into the nitty-gritty of the data. Just visually, you can see right eye versus left eye, certainly a big difference in ability, and certainly right eye versus left eye, a lot of chatter. So it's not surprising to me she's complaining of all these visual symptoms if in 3 minutes of measuring, this is what her eyes are doing. And if this is happening for her all day long, I understand why she may be having some visual symptoms. So we decided to go forward into doing some neurovisual rehabilitation therapy. And we did it for 12 weeks and 12-week data. So again, still everything is much cleaner. Right eye versus left eye in circular pursuits, horizontal pursuits, vertical pursuits, et cetera, much cleaner than before. And so we're chatting during the assessment. She's telling me, well, now when I'm driving, what I'm noticing is when I'm looking from far at the street signs to my dashboard, like I'm noticing still a drag in my vision. But she's able to see her phone, and when she walks, there's no more movement, so she can go to the store and she's not feeling so overwhelmed. Her after images were reduced, her vision was much less shaking. But what's super interesting was, you know, when I first met her, she wasn't driving at all. She wasn't really doing much of anything. She couldn't do much of anything. So the effects are so gradual that functionality seems to increase, and they go back to life without realizing how much they're doing compared to when they started. So by this time, she was driving to my office by herself. It's an 2-hour drive each way, and she was doing it efficiently by herself. And her husband went back to work. So life could resume for her, which was a beautiful thing.
What we're doing is looking at processing and how that affects motor function. So it does give us the opportunity to look at the overall system And it also gives us the opportunity to apply some of our testing to other areas of sensory dysfunction that are commonly associated with visual snow, as outlined by Christoph. One of the advantages is that I think we are not far away from developing objective measures of improvement rather than subjective measures of improvement. And I think that this will be very important for trialing various rehabilitation methods.
So MBCT is an established 8-week course, and it was based from an 8-week course called Mindfulness-Based Stress Reduction that was first created in 1980s in Massachusetts, Professor John Kabat-Zinn, which then was modified 20 years ago to combine the evidence for cognitive behavioral therapy and the MBCT, the mindfulness evidence based on the 8-week MBSR course. So it's been developed 20 years ago with lots of evidence published since for the treatment of anxiety and depression. And since then, it's been modified for various things. And I wanted to modify this for the management of visual symptoms, because one of the things that I see also, which I'm sure has resonated with a fair few of you, is that there is understandably anxiety associated with this. And I hear a lot of people mentioning that stress could worsen their symptoms, or this creates stress. So of course, the hypothesis therefore was that to test whether MBCT vision, meaning modified for vision, can be used to modify, improve, is the hope for people who have visual snow syndrome. It was very encouraging. With 6 people, we had 1 dropout, 7 in that group, 1 dropped out because of work. This was a face-to-face thing. And this is just remembering, it was just a scale of analog scale from 0 to 10, a self-rating, just to get a feel whether this feasibility thing has any direction at all. So we just asked them to rate the severity, their own rating of what they consider how severe it is, and also the impact of their vision symptoms on their life. And just remembering, so this is the results at 20 weeks in the gray bar, and that has showed a significant improvement. And this was during the pandemic. And they tell me that from the qualitative analysis that, they felt that despite, if it was not for the pandemic, they felt it would have been worse. So this suggests that there is a possible signal here, remembering there is a possible signal. The other thing to share that would be exciting to this group is that in December 2020, Yes, December 2020, or thereabouts, just before I spoke with Paul, there was just the publication of MBCT used for tinnitus. And the paper describes the tinnitus like the kind of tinnitus that we would see for people with visual snow. And it was only 15 patients, and it showed a statistically significant difference, published in Frontiers Neurology. So very exciting. My hope, first I have to do my duties and deliver the results. So I will share this when it's available. And I hope that if it shows that there is something to this, that the next stage would be a wider reach. So as part of the modification that I've had to do because of the COVID impact, I have been delivering, we have made amendments to do this virtually by video. And it's been going very well. And there has been the delivery of MBCT programs itself, nothing to do with this research study, but as a result of the COVID impact, a lot of the MBCT type work has transferred to virtual setting. So we were able to do that. And I will, of course, get the focus group feedback when we finish with this group. But so far, it's looking very good model, which makes it promising if there is appetite for more international collaboration, for us to deliver this for a wider reach.
I've been listening and appreciating all that you all are doing. It's really, really exciting. 2 thoughts. One is about halfway through the meeting, there was a discussion about how to stimulate deep targets in the brain, like the thalamus. And I'm part of a collaborative that's trying to figure out ways to use flickering lights and clicking sounds and other interesting combinations of sensory stimuli, even tactile stimuli now, and can appropriate combinations effectively stimulate deep targets in the brain. And there are now 3 clinical trials ongoing for Alzheimer's disease, all 3 of which have reported cautiously. These are small trials, as many of you have discussed. It's been hard to do human trials in COVID, but all 3 trials are showing progress, which is really exciting. Alzheimer's is one of the most intractable diseases of all time. So I'm very interested in ways of using our different sensory inputs in combination to effectively become a brain stimulator. And so eager to brainstorm with people and to help people think about this if that's of interest. The other thing we're doing for deep stimulation is trying to combine multiple stimuli so that they'll intersect in the brain. So we had this idea that we published a couple of years ago, what we call temporal interference brain stimulation, where we can deliver multiple stimuli, and where they overlap, we can try to engage neurons. Now, how does it work in humans? This is an open question. As I think many people have alluded to throughout the conversation, stimulating deep targets non-invasively is a fundamentally difficult thing to do. Nevertheless, we have convinced a Swiss company to start making these temporal interference stimulators. And I think they're going to try to launch like an early adopter program if people want to try it out. I'm not a doctor, I'm an inventor. So, but if there's interest in that, the company's called TI Solutions. I'll probably join it in the interest of full disclosure as a co-founder, just to help them think about it. But I'm not linked to the company currently. There are ways to help stimulate deep targets. That's something that I'm very interested in, both in my academic role as well as getting these things out into the world. So those are 2 thoughts that came to mind as I listened to everybody's wonderful presentations.